Good morning again to everybody. It's really a pleasure to be here with you and to have this communication concerning the impact of some of the abstracts been presented in this meeting. In terms of what the new drugs can really change the quality of life of patients, we have selected two papers. Both are coming from the Spanish group, but one is, you will see later, is coordinated by Professor Fornes on behalf of International Group. The first one is interesting because for ones of you that knows the problem of liver transplantation and the recurrence of hepatitis C after transplantation, it's really reported in 70–80% of the cases. What's happened, the drugs that usually are used for the chronic hepatitis, they do work well in chronic hepatitis, they work much less in the setting of transplantation. And in fact, with the old drugs, we never reach more than 30–35% of sustained biological response. It means that the dreadful news is that nearly 30% of the patient will have already the cirrhosis in 5 years' time, meaning that you have to discuss how to do with that and if they need to be retransplanted, which of course is not a success of transplantation. So what we found interesting, and I think for the media is relevant, is that we need really to stratify the patient with the different risk to develop the recurrence of hepatitis and then cirrhosis after transplantation. And from this group, they evaluated a huge number of patients transplanted for hepatitis C at Barcelona University Hospital. They selected 172 patients who had a very mild disease. So the prognosis was very good. However, among those patients in a long-term follow-up, the author identified that there was a tiny, despite much less, but there was the risk to develop the cirrhosis. And that was 3% at 5 years, which is for sure is definitely much less than the ones that I have reported to you, which is 30%, but 13% at 10 years. So it means that there is a subpopulation of fit patients that, despite that, can develop the cirrhosis. In a very, I would say, simple way, because it's a tradition, of course, it's a common use in a clinical practice to measure the transaminases in a patient after transplantation. This group found that there was a cutoff about 60, which is not a very high AST levels. It's transaminases is report in this way, reflecting the liver function. And there were already the patient with higher than 60 units at 1 year after transplantation AST with a higher risk to develop fibrosis. And more than that, when they thought that even the donor age would have an impact, you know that now we have donors age 70, 80, 90s. We have a paper in Italy published with a donor age 95. So it means that everybody can be a donor, but since the population is getting older, also the donor population is getting older, and it means that the donor age can have an impact, a negative impact on the HCV patients. So that was a smart way to see if the combination that you can see in here, the combination of the two risk factors, such as the donor age greater than 50 years and AST greater than 60 at 1 year after transplantation, would increase the risk to develop fibrosis in a very stable population. That was smart, and since we have the chairman, that's one of the best representative of the non-invasive fibrosis evaluation in the liver, they perform the fibroscan instead of the liver biopsy, or they performed the liver biopsy in some of them. But anyway, it was easy to see that at 12, 18, and 24 months, when they performed the fibroscan, there were two populations. One having an increasing, which you see in red, is the ones that then they develop the cirrhosis. So I think the final message of this paper is that this population can have a good outcome, but if we move to the antiviral therapy, to the new drugs, it means that we have to consider also this subgroup of patients that had not been treated in the past. Now that we have the new drugs, we can really treat those patients, and to avoid they can develop a subgroup of them, liver cirrhosis, without the antiviral treatment. So I think this is a nice study, and open to us the mind to go back home and to see, probably we have to look back to the patient that we haven't treated in the past, and they should be treated. The other paper that we thought is worthwhile to discuss with you, again, you see Professor Forns as the leader, but this is an international study. I think we have heard so many presentations during this meeting, but for us that dealing with the transplantation, it's just the opposite of what we presented before. There are a subgroup of patients with a very, very bad recurrence of the hepatitis C, which means developing the severe fibrosing cholestatic hepatitis. They are all patients that will die. Surgeons are not happy to retransplant those patients because they will re-recur on the second liver. So really, they are going to die, nothing else, unfortunately to be said. The compassionate use of sofosbuvir for those patients is very selective. And Professor Ford presented here the results of the first 104 patients. They've been treated with sofosbuvir and ribavirin, and there was the use of PEG interferon was left to the choice of the center. I think this is the message. Then I will show you some data related to liver function, but I think this is the message for you that 62% of the patient improved. So I think that's, we haven't seen things like this in the past. And as I said, the prognosis of fibrosing cholestatic hepatitis is really very bad, and all of them, or 95% of them, will die. And as I said, these are just the numbers. Improving the bilirubin, albumin, INR, and decreasing the MELD, which is a score of the liver and kidney function. Of course, the drug together with the PEG interferon still have some side effects, but not really so many, 6% treated related. So I think the results of this paper are very encouraging, and we really hope that in the future, having this 70% improvement and stabilization will really open the use of these drugs for the patient, possibly before they will develop this bad feature of recurrent hepatitis C, but for the patient that already are transplanted, to avoid them, or to offer to them at least an option, whereas in the past we didn't have so many options. Since my interest in liver transplantation and hepatitis C is also related to the quality of life, it comes quite naturally that hepatitis C will affect quality of life. This has been described several times because it has some, let's say, neurotropin, so it likes the nervous system, so the virus itself. It means that we can have subcognitive abnormalities, but also we can have some effects on depression, fatigue, insomnia. And in fact, what's happened was really shown by the recent paper that was published in Journal of Hepatology, where they analyzed with a questionnaire on the quality of life, the difference comparing the standard of care treatment, which is PEG interferon and ribavirin, with sofosbuvir and other new drugs. And what they show that avoiding to have the side effects of the old drugs would improve the quality of life when they evaluated those patients. And of course, killing the virus will improve all symptoms, such as most of the symptoms, such as the insomnia, the fatigue, they are related to the virus. So I think this is the double result that we can have with the new antiviral therapy.
This is going to be mainly hepatitis C, but I'm just interfering with hepatitis B. I will show the data of 3 studies on the treatment of hepatitis B, where in all of the studies, the aim was if we could shorten treatment duration in e-antigen positive chronic hepatitis B in a way. And for this, if I can start, combination therapy of pegylated interferon alpha in combination with nucleoside analogs was used. I mean, this approach has been tested several years ago in several studies, and the results were all negative. So there was no difference between combination therapy and monotherapy with pegylated interferon. but based on a few studies which suggested not that the combination therapy should not start from the beginning on, but rather sequentially. These studies were planned, and here are the results. I will provide you with the results. So the first study is from the Far East, from China, from Hong Kong, with the title Combination Therapy with PEG interferon alpha 2A and a nucleoside analog for e-antigen positive chronic hepatitis B patients, results of a large randomized multicenter double-blind placebo-controlled study, the NEED study. This was a phase 4 study. The objective was to evaluate the efficacy, and efficacy was assessed by e-antigen seroconversion, because e-antigen seroconversion, e-antigen positive chronic hepatitis B is associated with ALT normalization, improvement in liver histology. So it's a good surrogate endpoint for treatment assessment. So the aim was to evaluate the efficacy of PEG interferon alpha 2A given for 48 weeks in combination with a 6-week nucleoside analog, either adefovir or entecavir, in e-antigen positive chronic hepatitis B. As I said, primary endpoint was e-antigen seroconversion. Here is, you can see the design of the study. Arm A received 6 weeks of placebo and then PEG interferon alpha 2A. Arm B and C were the combination arms. These were either entecavir or adefovir combined with PEG interferon alpha 2A. But as I said, 4 weeks monotherapy with nucleoside analogs, and then 48 weeks or 44 weeks, no, 48 weeks of combination therapy with PEG interferon alpha 2A and adefovir or entecavir. And here are the results. The brown line is PEG interferon monotherapy. The green is PEG interferon entecavir, and the blue is PEG interferon adefovir. And as you can see on the right, there was statistically no significant difference between the 3 groups in terms of e-antigen seroconversion. So in summary, a short course of nucleoside analog followed by PEG interferon alpha 2A is safe and well tolerated, but this kind of combination strategy does not increase e-antigen seroconversion rate compared to PEG interferon alpha alone. And thus, this is a negative study. Now, let's go on. This is another study from the Far East, sequential combination therapy with nucleoside analogs and PEG interferon in e-antigen positive chronic hepatitis B patients with prior exposure to long-term use of nucleoside analogs. So on the left, there are 192 e-antigen positive patients, if you follow this. They are all on treatment with nucleoside analogs. By the way, this is a retrospective study, so it's not a randomized controlled study. This is retrospectively assessing the database of this group. So we have 192 patients who are on long-term nucleoside analog treatment, and there were, out of these 192, 83 patients went on to receive sequential combination therapy with PEG interferon and nucleoside analogs, whereas 109 continued to receive nucleoside analogs. After 48 weeks, treatment was stopped in both groups, and a follow-up of additional for 20 weeks was done. And here are the results. As you can see, those who went on to combination therapy had, in terms of the combined response, which was e-antigen loss plus an HBV DNA less than 2,000 international units per ml, had 60% of this response, whereas those who continued on nucleoside analog, in this group, this was only 14%. And more importantly, the ideal endpoint of hepatitis B treatment is actually surface antigen clearance. this endpoint is used much less often because it is very difficult to achieve. In this group, the combination treatment, 28% had surface antigen clearance. Those who continued on nucleoside analog, 0%. So this is a striking result. And they also observed that those who are going to respond to treatment can be decided upon based on baseline surface antigen levels or on treatment surface antigen levels. What is shown here is baseline surface antigen levels. On the left, A and B is either combined response, so E antigen loss plus DNA less than 2000, and B is surface antigen loss. And as you can see, in non-responders, they have much higher baseline surface antigen levels. If you go to the right side of the slide, you can see the black bars are represent baseline surface antigen levels less than 1,000 units, and the gray bar above 1,000 units. As you can see, all patients who had a baseline surface antigen level of less than 1,000 international units per ml achieved a complete response. E antigen clearance plus less than 2,000 HBV DNA international units per ml. And 91% who had less than 1,000 units per ml of surface antigen at baseline had surface antigen loss, whereas this was only 18% with those who had about 10,000 international units per ml. So the results can be summarized as sequential combination therapy of nucleoside analogs and PEG interferon effectively result in high rates of complete response and surface antigen loss in patients with prior long-term exposure to nucleoside analogs. Surface antigen level at baseline, and I did not give you the results of on treatment surface antigen levels because of shortage of time, but also week 12 and week 24 surface antigen levels appear to be strong predictors of treatment responses in the combination group. In patients with surface antigen levels at baseline less than 1,000 international units per ml, as I showed you, 100% achieved complete response, 91% achieved surface antigen loss. In patients who had at baseline more than 1,000 international units per ml, some still responded, and those who responded could be somehow predicted because this response rate was significantly lower in those who experienced no decline in surface antigen levels at week 12. Patients with surface antigen decline of more than 0.5 logs at week 12 and more than 1.5 logs at week 24 still had a chance to respond. Now, the final study. This is a study from the Netherlands. It's an investigator-initiated study, but with the participation of European as well as Asian centers. In this study, the title of the study is Adding PEG interferon to entecavir increases response rates in E antigen positive chronic hepatitis B. So this is the ARES study, a multi-center randomized clinical study. I'm skipping the rationale and showing you directly the study design. Patients who were treatment naive were started on entecavir for 24 weeks, and then they were randomized to receive either on the top PEG interferon alpha 2A plus entecavir for another 24 weeks, or on the lower part continue on entecavir for another 24 weeks. So altogether at week 48, this is the first end of study, I would say. If they were responders to treatment and response was defined as E antigen loss plus an HBV DNA, this time not lower than 2,000 but 200 international units per ml. If they had responded, they were given entecavir for another 6 months and then stopped. If they were non-responders, they received entecavir for another year. This was the same in both groups. How was the response? This is a busy slide, but I will try to go you through. On the left side, first of all, the green bars and the green line is the group who received, as you can see, entecavir plus pegylated interferon. The red one is entecavir. As you can see, in terms of E antigen loss at an HBV DNA less than 200 international units per ml, which is the defined response, was higher with combination treatment. It was not significant, but it was numerically higher. You have to also consider the number of patients included into the study. In terms of E antigen seroconversion, not just E antigen loss, but seroconversion, there was a significant difference in favor of combination treatment. And in terms of surface antigen levels, achievement of surface antigen levels of less than 1,000 units. Again, there was almost a significant difference between the two groups. On the right side, sustained response, so sustained E antigen loss plus HBV DNA, again numerically different. And in terms of E antigen seroconversion, significant difference. In terms of the latest ALT, normal ALT, and less than low DNA, there was a significant difference. Now, in conclusion, this study showed that PEG interferon alpha 2A add-on leads to higher E antigen and surface antigen response rates compared to entecavir monotherapy. Combination of PEG plus entecavir was safe and well tolerated, and PEG interferon add-on appeared to prevent relapse and may therefore facilitate the discontinuation of nucleoside analog therapy. So in summary, if we summarize the results of all three studies, these studies were aimed to clarify the optimal use of combination therapy in chronic E antigen positive chronic hepatitis B. Chronic hepatitis B patients who failed on prior long-term exposure to nucleoside analog antivirals demonstrated high rates of response and surface antigen loss when prescribed a sequential therapy with pegylated interferon and nukes. Adding PEG interferon to entecavir was shown to enhance response rates, but shortening the duration of nucleoside analog therapy component down to 6 weeks did not achieve the better results obtained in the first two studies in terms of combined treatment. So this would be my report. And
thank you very much, Laurent. I will present, as Laurent said, the final data of the phase 3 studies that we have seen at ILC today, yesterday, and some of them we'll see tomorrow. I will start with the AbbVie combination in Sapphire 1. This was just presented a couple of minutes ago by Jordan Feld, who is here in the room. And this is a phase 3 study of the AbbVie regimen, which we would refer to as the 3D regimen, which means 3 drugs. The 3 drugs are ABT450, ombitazvir, and dazabuvir. And this is a combination based on drugs hitting 3 different steps of the viral life cycle. And this is a phase 3 study in naive patients without cirrhosis, genotype 1 patients who have never received treatment, 12 weeks of treatment in the group A, and 12 weeks of treatment in group B with the first part of 12 weeks of placebo. 3D plus RIBA. Huge study, more than 600 patients, and these are the results. The SVR rate, which means virological cure, so these patients got rid of the virus, was overall 96%, breaking down the data by subtype, genotype 1A versus genotype 1B, no difference, 95% versus 98%. And the horizontal bars that you see are the historical control. So what you can achieve in these patients with PEG interferon, RIBA, and tenofovir, which is what we have as standard of care in most European countries. And you can see that there's a big difference, 20% increase in SVR rates, and the study showed superiority of this regimen compared to the current standard of care. Another important message, you can see it down here, very few patients who had a virological failure during treatment, And most of the patients who failed treatment actually discontinued treatment or did not come for follow-up visits. So this was a very, very effective study, very effective treatment regimen. So in this study, genotype 1, naive, non-cirrhotic patients, very high SVR rates, very good tolerability. The serious adverse events rate was from 0.6 to 2.1, so very, very low. I would say this was a highly, highly effective regimen in this treatment population. I will then move to the PEARL-3 study, which is similar in terms of patients that were enrolled, genotype 1b, naive patients, but just genotype 1b, no genotype 1a. You might know the genotype 1b is highly prevalent in the southern part of Europe and is slightly easier to eradicate with the current regimens and with this regimen. So this study, the 3D regimen plus minus ribavirin. So we were looking at if we needed ribavirin in these patients. 12 weeks of treatment, huge numbers, more than 400 patients, and these are the SVR rates, 99.5, 99%. And you can see that without ribavirin, you have 99% SVR rates, which means in genotype 1b, naive patients without cirrhosis, you don't need ribavirin. You can use this 3D regimen, and you have a very high chance of getting rid of the virus. Once again, the safety profile was very good. Tolerability was very good. You can see by the numbers that very, very few patients did not get an SVR. Discontinuation rates were lower than 1%. I will move to the SAPPHIRE-2 study, which was presented by Stefan Zoidzem yesterday. The first presentation of the opening session, you might remember this. The room was packed with people, so everyone was paying attention. A very important study, phase 3 study of the 3D regimen from AbbVie. But here we're looking at treatment-experienced patients, so patients who have failed PEG interferon plus riba. Once again, these patients are not cirrhotic, so no cirrhotic patient was enrolled in this study. And these are the SVR rates. So you can see that overall, 96% of these hard-to-cure patients, these patients have failed a previous course of PEG interferon plus riba, 96% got an SVR, and breaking down the data by subtype, 1A versus 1B, no difference. So 12 weeks of the 3D regimen plus riba in these patients gets you to 96% efficacy rate. This is breaking down the data by previous type of treatment failure. Obviously, some patients failed with a relapse, which means that they responded during treatment but lost the response after treatment. Some patients did not respond completely during treatment, the null responders, and some patients had some degree of viral response during the first treatment. They were retreated with the 3D combination plus riba, and the SVR rates are in the 95, 100% for all these groups. So no influence of the previous type of treatment failure with the 3D regimen plus riba in these patients. Once again, the conclusions, incredibly high SVR rates. You have seen this in the 96, 97% range in genotype 1, genotype 1b. Excellent safety profile. Very few patients had to discontinue for side effects. Then the serious adverse events, you can see it down here, were less than 1%. So very, very high efficacy rate and optimal tolerability. I will then switch to the Gilead combination of sofosbuvir plus ledipasvir, which was presented yesterday as the last presentation by Ed Gain. And this is quite a complex study because it is looking at an easy treatment, sofosbuvir plus ledipasvir, which is a fixed dose combination, 1 pill a day, but in various groups of patients. You might know that sofosbuvir is a polymerase inhibitor and ledipasvir is an NS5 inhibitor. They have been combined in this FDC, which stands for fixed dose combination. It's 1 pill a day, no food effect, very easy in terms of adherence for our patients, and more than 2,000 patients have received it thus far. So looking at this combination in this study, we're looking at 3 groups of patients. First of all, genotype 1 patients who have failed a previous regimen in containing sofosbuvir. So patients who have failed a sofosbuvir-containing regimen. The second group is genotype 1 patients with decompensated cirrhosis, so with very, very advanced disease, with ascites, with encephalopathy, very sick patients, which currently are contraindicated to any PEG interferon-based regimen. So this is an important group where we have to study these interferon-free regimens. And the third group is genotype 3 patients, which are a group of patients who currently is not that easy to cure and where we need improvement in terms of efficacy rates compared to the current regimen. So in these 3 groups, The study, as I told you, is quite complicated. 12 weeks of treatment of sofosbuvir plus the dipasvir plus or minus ribavirin. You can see that the first group, patients who have failed sofosbuvir in a previous regimen, ribavirin was there. In genotype 3 patients, there's a randomization to see if ribavirin is essential or not. In the second group, and this is important, the patients with child puke B, the ones with decompensated cirrhosis, no ribavirin. 12 weeks of treatment, so the treatment duration is exactly the same in all these groups. First group, just look at the column over here, forget about the pie. This is the SVR rate. So the numbers are small, 19 patients, 100% SVR rate. Perfect. So patients who have failed sofosbuvir in a previous regimen, genotype 1, you retreatment with sofosbuvir plus the dipasvir plus riba, you get 100% SVR rates. Remember, the numbers are small, but 100% is 100%. Second group, the most difficult to cure patients, the most in need patients, the one with decompensated disease. These are child B patients. You can see on the left, 20% has ascites, 30% hepatic encephalopathy. These are very sick patients with a high risk of dying of the disease. And unfortunately, if you ask me, the SVR rates are not where we want them to be. 65% SVR rate, which is not bad, it's very good, but we're used to seeing 85, 95, so slightly lower than what we wanted. No riba. Keep this in mind because you can see that all the patients who failed had a relapse. So all the patients responded during treatment. Once they stopped, they had a relapse. And this means effectively that putting riba or eventually expanding treatment duration in these patients might increase the SVR rate. But with this regimen, 12 weeks, we are just at 65% SVR rate. Third group, genotype 3 patients. As I told you, this is a group that is hard to cure with the current regimens. Looking at two different regimens, the dipasvir plus sofosbuvir, no riba, the dipasvir plus sofosbuvir plus riba, same duration, 12 weeks. You can see that riba increases the SVR rates from 64% to 100%. Small numbers, highly selected center, some interpretation bias, but from what you see here, it looks like that if you add riba to this combination, you can have very, very high SVR rates. So I think to sum this up, you can see that the dipasvir plus sofosbuvir plus or minus riba is an effective treatment regimen in genotype 1 patients who have failed sofosbuvir in a previous regimen. It is effective in genotype 3 patients. I would say it's somewhat effective in patients with decompensated disease, but we have to improve on that 65% SVR rate. Let's go then to the last study. This is once again, we're looking at the AbbVie 3D regimen, the turquoise study, which will be presented by Fred Purdad. This is an international study. The regimen is the same. It's the 3D regimen plus riba, but we're now looking at patients with cirrhosis, that were excluded from the studies which I showed before, SAPPHIRE 1, SAPPHIRE 2, and PER-3. So these are just cirrhotic patients. Naive, experienced, some of them with child puke A6, A6 actually, some of them with low serum albumin. So some of these patients were very sick. So cirrhotic patients with advanced disease. And the treatment regimen is very simple. 12 weeks versus 24 weeks. Exactly the same regimen. The 3D regimen plus riba, 12 or 24 weeks. So the study is designed to assess which is the optimal treatment duration in these patients. And these are the SVR rates. 12-week on the left in green, 24-week in orange, 91%, 92% versus 96%. So no difference, very high SVR rates, 12 weeks versus 24 weeks. But if you break down the data and you look over here at the patients who failed treatment, you can see that most of the patients who relapsed, the 12 patients were genotype 1A null responders, which means that 12 weeks is perfect for cirrhotic patients with genotype 1B. It's perfect for genotype 1B null responders, but for genotype 1A null responders, you have to go for 24 weeks of treatment. So in conclusions, this study shows that the efficacy was very high in cirrhotic patients, irrespectively of either if they were naive or experienced, with 12 weeks of treatment with a 3D regimen plus riba. But in genotype 1A null responders with cirrhosis, you have to go for 24 weeks. And this is what we're expecting in the AbbVie label. In terms of safety, the safety profile was very good of this treatment combination. Okay, I'm very proud to be here on this podium on behalf of the incredible team you have here shown, which did an incredible team job, really, to get these EASL recommendations in less than 2 months. Once the EASL governing board and the secretary and the vice secretary, Laurent Castera, decided it was time to get some new recommendations in, Jean-Michel Pavlovsky, who has just joined us at the table, assembled this team, and we were able in just 2 months to get everything in, and it was really a huge team effort, and I'm very proud to show you the results of our work. So just a little background, which I'm sure you're confident with. We have had an incredible increase in SVR rates, which is cure of the disease, in the last 15 to 20 years. But this has been a slow process. We started in the late 80s, and finally, in 2011, with tenofovir and boceprevir, more than 20 years later, we had 75% cure rates. And all these changes and all these improvements were essentially looked at and described by the previous clinical practice guidelines by EASL, the 2011 one led by Antonio Craxi, and the 2013 ones led by David Multimer. But something has changed following the 2013 clinical practice guidelines. We have new drugs. Sofosbuvir was approved in Europe on the 17th of January by EMA. We have simeprevir, who has been given positive approval by EMA a couple of months ago, and will get final approval in probably early May. And we also have daclatasvir, that is likely to be approved in September, August, September, at worst October, at the European level. And these drugs have different profiles, but the main important issue is that they are either pangenotypic, like sofosbuvir, or they have an antiviral effect on genotypes that were not covered by peg-interferon riba and tenofovir and boceprevir. And by combining them, you can get effective treatment in most of our patients. So what we decided is what we wanted to look at these 3 drugs, what they were adding, the combination of these 3 drugs, their use eventually with peg-interferon and riba, and to give recommendations as the EASL. And the rationale that pushed us to give us this recommendation is easy. We wanted to support and assist physicians in their clinical practice, also healthcare providers and patients, to understand which was the best currently available treatment option. But the second aim we had, which was very important for us, is clearly still important because it's something we still have to work on, is really to have these update recommendations out to guide reimbursement and to guide a homogeneous reimbursement across Europe, because we don't want to have patients who have access to drugs in some countries and patients who have no access to effective drugs in other countries. We don't want a heterogeneous picture of Europe in access to these drugs. And obviously, this was a major issue because you know that in Europe, HCV is widely heterogeneous, not just in terms of epidemiology. We go from countries like Southern Europe, Italy, Eastern Europe, Ukraine, Kazakhstan, whatever, which is close to 3, 4, 5% prevalence rate of HCV infection, and areas where we are closer to 0.5, 1%, like Northern Europe. But also, there are different policies in terms of access to drugs, in terms of reimbursement rules, in terms of screening policies. So we wanted to have guidelines that were trying to be homogeneous and push all European countries to have similar access to effective treatments. And what we did is very easy. We looked at all these combination regimens, and we decided that 6 possible regimens were possible. And you can see that the 2 regimens are missing, peg-interferon and riba, and peg-interferon plus riba, tenofovir or boceprevir. We are not excluding these regimens from clinical practice. What we state very clearly is that if you don't have access to these 6 regimens, you should use peg and riba or peg and riba plus tenofovir or boceprevir accordingly to the previous clinical practice guidelines. So we are not saying that these drugs are contraindicated. We are saying if you have access to better regimens, forget about tenofovir, boceprevir, go with these 6 regimens. And from a clinical point of view, this slide got slightly messed up, but this is the genotype 1, 2, 3, 4, 5, 6. What we recommend is various treatment options, 6 options for genotype 1, 6 options for genotype 4, less options for genotype 2 and 3. We have a preferred option for every genotype, but we also show the other available options in terms of efficacy, safety, correct dosing, and eventually drug interaction issues. And this is very technical, so it's not important, but the most important thing I would like to share with you, that we also look at special populations. And I think there are some key messages to get from this slide. First slide, HCV, HIV co-infected patients should not be looked at as a special population anymore. And this is very important. These patients have very, very high SVR rates with some of these regimens, exactly the same as non-infected patients. No drug interactions with some drugs, with HIV, antiretroviral therapy. So this is not a special population anymore. The second important question, message I want to get through is that in some patients, the one with cirrhosis, following liver transplantation or pre-transplant, obviously interferon-free regimens are the preferred option. So no need for interferon in these hard-to-cure patients where the safety profile of interferon is not optimal. Patients on the waiting list, the decompensated patients, we were very cautious. We suggest to treat only patients with decompensated cirrhosis if they are on the waiting list. Otherwise, try to get them on a trial, try to get them into an experience center, but we do not suggest broad access to these drugs to all decompensated patients, but only to those on the waiting list. And last point, hemodialysis patients, we have no data there. So we are very cautious. This is a group that needs treatment, and we hope to have data in the future, but currently we're very cautious in our approach, and we do not have strong recommendations over there.